My name's Michelle Rhodes and I'm the Director of Nursing Chief Nurse at United Lincolnshire Hospital Trust. And Mark Radford asked me to talk at the launch of the Safeguarding Workforce document a few months ago. And I made the joke then, and I'll say the same thing again. I actually think it was because my story and our story at ULHT makes everybody else feel better. So I think that's why Anne's left it till the end of the day to put me on. Actually, it's nothing to do with ward to board. It's because, you know, we do deal with an awful lot of stuff in Lincolnshire, and the whole point of this conversation with me is that I'm very open, I'm very honest, and I do say it how it is. So I will talk to you about the problems that we face, and I will talk to you generally about the tough decisions that we've had to take and the discussions we've had at the Trust Board with regard to some of our services across Lincolnshire, and many of you will be in similar situations as well. So now I originally entitled this Making Tough Decisions and Surviving, but we've made it a bit more posher. So it actually says where it is on the agenda now. So, okay, so I'll start off a little bit at first just so you understand a bit about Lincolnshire. So we have 4 hospital sites that are 35 miles apart. We have many tractors, many fields, and very poor phone reception. So travelling between sites takes over an hour and 15 minutes, and you can't really make any phone calls between there. Not that we should when we're driving, but even if you're hands-free, because you don't have a signal. So we have 7,500 staff, just over 1,000 beds, depending on, as will be in many of your hospitals, how busy you are and how many escalation areas you've got open at the time. And we're just over £430 million turnover. So for a non-teaching hospital, we're a big organisation that's spread very far and wide. We have 750,000 public across Lincolnshire. So we have 3 A&E departments, 2 hyperacute stroke centres, 2 trauma units, 2 maternity units, 2 paediatric inpatient units and 2 neonatal units, and a partridge in a pear tree, and all of that goes along with it. You can imagine where this story is going, can't you? So when you have, for those of you that work in rural areas, when you work in our type of organisation, it's really difficult for members of the public to access healthcare. So I'm from Nottingham. I don't live in Lincoln. I travel in from Nottingham every day. But when I was little, I used to go to the caravan with my nana in Skegness and Sutton-on-Sea and Mablethorpe. Well, that's the population we serve now, and I serve in Lincolnshire, and I see now how difficult it is for them to access care when they live on the East Coast in particular. So, some information about us. We had a CQC visit last year. We were inadequate prior to that, and we've gone up now to requires improvement, which for many of you would be a very small jump, but for us it was huge. And the amount of work to get from inadequate to requires improvement was massive. 2 of our hospitals are rated as good. 1 of our hospitals is rated as requires improvement, and we have 1 hospital, our Pilgrim Hospital in Boston, which is on the East Coast, which is rated as inadequate. We are in special measures for quality for the second time, and we've gone into special measures for finance as well. So, bit more about the importance of trust leadership. I've been at this organisation for 8 years. I spent 5 years as the Director of Operations there, and then 3 years ago I became the Director of Nursing. It hadn't been my intention to stay as the Director of Nursing in Lincolnshire, but actually after some consideration and some persuasion, that was the right thing to do, and I'm very proud of what I do and where I work. But in my time, in those 8 years, we've had 4 chief execs, 4 chairs, 4 dons. I was the first substantive don for 5 years, 5 medical directors and 6 FDs. So when you think about the context, and I'm not the only chief nurse that's working in this kind of environment, but when you think about the context of having a conversation at Trust Board and you don't know 1 month to the other who's going to be sat around the Trust Board and what their thoughts will be, it's hugely important to use all of the information that you've got today to provide to your chief nurse, or whoever it is that presents that information to the board. So to me, this is what special measures feels like. It feels like you're buried in concrete all the time. You have massive scrutiny. Everybody everywhere is looking at what you do. And we're very lucky in Lincolnshire that we've got a really good relationship with NHSI, but they ask for so much information, and the CQC and Health Watch and everybody. It's really hard. So it is really difficult for all of us at the minute. It's really difficult to work in healthcare, and whether that's as an AHP, as a nurse, as a doctor, whoever it is, it's tough out there. So our hospital, the way it looks is we've got about 2,200 registered nurses and midwives. We have 700 healthcare support workers and about 300 consultants. I'll just give you that as a sort of, so you can see the size. So I'm sorry you're not going to be able to see this at the back. This is what actually goes in our board report. So I took it out our most recent board report, and essentially what it shows is that our vacancy rate for nursing is around about 18%. So we have some wards in our hospitals that have a vacancy rate of 50%. So when I listen to Peter, I get really, really scared because I see the research, I read it, and then I have to go and do the day job and think, so how am I going to actually implement what that evidence says to be able to make it safer for patients? And it really is tough. So we've about 18% for vacancy. So this is our agency expenditure, and that is also from our public trust board. And what this shows is month by month how much we spend as an organisation on agency, whether that's medical, nursing predominantly, that is on here. And you can see for nursing that the M1 month 11 is of course February, and for February we spent £1 million just in February on agency nursing. So all the information and the evidence that's presented about registered nurses and increasing the hours of registered nurses on the wards, when you do that, I'm really fascinated to understand if they're substantive nursing hours or if they're agency nursing hours, or how that all plays through in the evidence and the research. And it's something that I'd certainly like to look at. The purpose of giving you all of this information is so that you can see that you're not on your own, that we're all facing tough times, and actually some of us more than others. So you can see now why we're an organisation who has a nearly a £90 million FRP, which is our financial recovery programme. We are actually going to be better than that at the end of the year, she says, and I know this has been videoed, so the FD will be watching this, I'm sure, and hearing me say that. But the main reasons for our financial deficit are really around the high numbers of clinical vacancies that we have, and that's not just in nursing, that's in doctors, and particularly in some of the AHP areas as well. Midwifery is the area for us where we don't have any vacancies. Actually, we have a very low vacancy rate across our sites. We're getting, like many of you will be, I've been gold on call this week, and I've been up half the night. I'm sure many of you have as well, with the amount of patients that are coming through ED at the moment. So we see a higher level of medical non-electives. The way that the contract and the system works nationally at the moment, we get fined for not achieving this, and we get penalties for not achieving that, and of course that just makes the financial position worse, and that has had a massive effect on us as an organisation. And we spend quite a lot of money, about a third of our deficit, on supporting our fragile services. So at the beginning, showing you that we have 3 A&Es, 2 paediatrics, 2 maternity services. Trying to staff 1, you'll all know, is difficult. Trying to staff 2 is near on impossible. So we spend an awful lot of money on supporting those services to keep them going. So the impact on our staff is that we do have low morale, and our staff survey results are poor in the area of, would you recommend this place for people to work? Would you recommend your family coming here? And out of all of the things in that report, and all of the things I say to you today, that's the thing that breaks my heart the most. So this is so important that we get this right. I mean, having said all of that, I'm going to put a positive on it now, because this is not a downer presentation. Our mortality rate in Lincolnshire is the lowest it's ever been, ever for us. So we've got some work to do on shimmy, but our mortality rate has improved significantly. Our harm-free care is actually about at the national average for new harm-free care. So we're below the national average for falls. We have halved our number of grade 3 and 4 pressure ulcers in the last year. So the work we are doing, we're doing something right, but what we haven't done is manage to shift the burnout, shift the, those nurses that have a low morale, that because they're all doing extra shifts, they're all doing lots and lots of work to stop patients being harmed, but it's taking a toll on our workforce. So when you're in financial special measures, or when you are in an environment like we are across the country at the moment with trying to save money as everywhere you can, the nurse establishment review for us was massive. So we had, as I showed you earlier, several finance directors that came through. All of them were interims, all of them were in there to say, okay, how are we going to save money, how are we going to do this? And we had lots of discussions at our exec team and with the teams on the ground about how we set the nursing establishment, and everybody's talked to you about that already and the importance of that, and there was conversations about if it's outturn, if it is safe nursing care, if it's taken from that, the establishment review, how do you do this, how do you do this, how can we decrease the amount of money we spend? So somebody else has just said this, well, we call down, as you do. So it's a bit like having and I think Jeremy Clarkson's doing it now, isn't he, on that phone a friend thing, on the millionaire thing. That's what you need. You need to phone a friend, somebody that's done this. So I have great relationships with Nottingham because I trained there and I know the people there, so they were supportive. Leicester, we've got colleagues at Leicester were supportive, and we got them in. We got them in to help us, to scrutinise what we were doing, to see if I was going mad or if this was right. And then we got Anne and the team in, and I've got a fantastic deputy. I was delighted to hear Julie talking a minute ago, because my deputy has that enthusiasm and that knowledge, and she's just fabulous. So she works with Anne and has got all of this stuff together, and we made a real thing about using an evidence-based tool, which was for us, which was SNCT. We use the Safe Care Live data, a bit like Julie was describing, and I won't go into the detail of it, but we have a multidisciplinary discussion, so we get the major... Oh, I'll keep doing that, don't I? So because I get a microphone, I want to start singing. So we get the matrons in, we get the heads of nursing in, we get everybody in. But we get finance and HR as part of that review as well, so they're in the room while we're having these discussions. We did get Leicester originally to look at it. We did get some support from Nottingham as well, who had a much more established team than us, because we knew that we would have the pressure on us to say, how are you going to cut down the number of nurses? How are you going to cut down the number of physios? How are you going to cut down the number of midwives? And what I needed to do was be prepared at the Trust Board to have this conversation. And we have a conversation and have introduced something that we call Team Around the Patient. And this is the bit when I listen to Peter and I read the research that I think to myself, am I doing the right thing? What is this, is this the right thing to do? And what we are doing in Lincolnshire is growing our own. So we've started a whole programme where we have, well, in my day, because I'm a bit old now, the pupil nurses, but of course they're cadet nurses, we call them now. So we have cadet nurses, we have health cares, we do have nursing associates. They're huge to us. We've got 20 of those at the moment that are on our wards training. They've already trained, they're qualified, and we have another 50 that we'll be putting in place. And we'll probably end up with one nursing associate on every shift on every ward across our organisation. So, and I'm not ashamed to say that, and I'm not ashamed to say that I'd be really happy to have a speech and language therapist or a physio or an OT to be the ward lead on the stroke unit, on a healthcare of the elderly ward, on the respiratory ward, because I think it's the right thing to do. So Team Around the Patient for us was using the information that we have from Safe Nursing Care, was looking at the red flags, was triangulating all of our data to make the best team to fit on that ward for those patients. So and that was what that was about, and I took that to Trust Board, and we made that decision at Trust Board because we knew that putting in additional health cares or putting in nursing associates or putting in anything that was additional to a registered nurse would cause a discussion, as we've had when Peter presents the evidence earlier. So, but for me it was, okay, do we have bank and agency or no one, or do we pull this team together that is sitting on this ward, that are substantive, that want to be there and can provide this care? And I think that is something that, and Peter may say that I'm incorrect, but I think that's something that we do need to research and we do need to look at in comparison. So the safeguarding, the workforce safeguarding paper came out last year. I'm not going to go into it because everybody had talked about it already. So it does really give you fantastic guidance. For us, it was a bit of a moment where you think, oh God, not doing that, let's sit down, go through this. And we did. We went through it line by line to make sure we were following the guidance, and it was very helpful. So the tough decisions that I just wanted to focus on just for the last 10 minutes really is two of our services that we have in Lincolnshire that have been really fragile for us. So the first is our emergency department at Grantham Hospital. So that was a 24/7 emergency department. It had a take that was it's a smaller hospital, so they didn't take acute strokes, they don't take acute medicine or acute surgery, but it was a 24-hour doctor-manned hospital A&E department. And then our paediatric inpatients at Pilgrim Hospital. So we have two inpatients areas, two inpatient wards for children, and because we had significant staffing issues on both of those areas. So for Grantham, we have two consultants at Grantham that run the A&E departments, but they're both locums, and so we don't have any substantive consultants there. We have 19 consultant posts across Lincolnshire, across the three A&Es, and we have 3 substantive, the rest of them are locums. So it was a conversation that we had at Trust Board with regard to Grantham, and a similar conversation with the inpatients at Pilgrim. So for paediatrics, we don't hit the national guidance, nursing guidance for the number of paediatric nurses that you need on a ward. We'd skill mixed as much as we possibly thought was safe to do that, so we needed to make some tough decisions. There were patient safety concerns from me, from the medical director, and from the Trust Board, but these are not small discussions to have, and the importance of having a team around you who can pull the information together and support that discussion at Trust Board. Bearing in mind that many of your Trust Boards will be, these discussions will take place in the public, as ours did. So we had half the population of Lincolnshire with pickets and all kinds of, I mean, it was awful for these people who thought they were losing their services. But the importance of using Safe Nursing Care Tool, or what tool it is, the importance of looking at CHPPD and at Model Hospital and bringing all that data together managed to inform the decisions. So we brought everything together for a start. We looked at everything you could think of, all our quality metrics, all our finance metrics, staffing metrics. We did that with the teams. Then we had a conversation at the exec, and we talked to NHSI, of course, because there is something about keeping the regulator on side. So as I say, I do have a good relationship with NHSI, but I also have a good relationship with CQC, and we're probably the only hospital in the country where our CQC, when they came to do our core services review last year, it was the beast from the east. So they got snowed in Belston at Pilgrim. So I had the CQC inspector in an apron with a mop working in A&E. So, and good for him as a nurse, he stood up and he did that. So, you have to develop relationships with regulators. It doesn't mean you get away with anything, and we shouldn't be getting away with anything, because this is about patients and patient safety, but you have to build the relationships with them. So giving those people the heads up is what the chief nurse, medical director, the chief exec will want to do, and they can't do that if you all don't give them the heads up. So we work on a no surprises rule. So we took this to the Trust Board, we had a big discussion, and we'd obviously done an option appraisal, which included risk assessments, and we had QIAs coming out of our ears around this, which is, Lorna from this morning is fantastic. She came up to see us and help us. She was really, really good, and the information she shared this morning, don't take that with a pinch of salt, because it is so important when this comes back, because it does. You get on the front page of the papers and on the telly. You need to make sure that you've done a full quality impact assessment. We obviously then took it with all the stakeholders. We had lots of conversations with patients as well. And then we went to the trust board, and that resulted in us closing our A&E department overnight a couple of years ago in Grantham, and we closed our paediatric inpatient services on the Pilgrim site. What we did was put a different model into both those areas, but we significantly changed the way that they operate. And the reason for doing that was not financially driven. It was driven absolutely by staffing levels and by the fact that we did not have enough nurses and enough doctors to safely give care to those families of the children and to those people that went into A&E. That's a really tough decision to make, and it has to go through an awful lot of rigour, but the assurance and not reassurance statement that several people have used today is massively important. So what did we do? How did we feel as a team? What was it like? It was a nightmare. So, you know, when you come to these tough decisions, I mean, I hope that you never have to be in a position to have to close a paediatric ward overnight or to close an A&E department. I wish none of us were in that position. But if you ever get into whatever it is that you find is a difficult position, you have to take a very, very deep breath. Underneath, you panic. I panicked a lot. So I sat in a corner, you know, thinking what we're going to do, how we're going to do this. But always, I came back to putting the patient right at the centre of this. No matter what discipline we are, no matter which place we work in, we all get up and go to work because we know it's the right thing to do for patients and their families. I've always been very, very open and honest, and our trust board is exactly the same. So we had lots of very open and honest discussions at the board in front of members of the public. The financial special measures has been the most difficult thing for me, and I'd be absolutely honest to say that I have struggled at times to be able to keep true to the values that I hold inside about patient safety, about quality of care, about doing the right thing. When we've tried to be stripped of money left, right, and centre, and that's not because people think nurses aren't worth it, or because people think, you know, AHPs or midwives or doctors aren't worth it. It's because we are in a really, really poor financial situation across the NHS, and we have to look for everything. So, but keeping true to your values is massively important. Working with colleagues, I talked earlier about my deputy Deb. I've got 2 deputies. I've got fantastic matrons, fantastic sisters. I meet as chief nurse with my ward sisters and department leads every single week. We meet for an hour. We have a conversation about what's happening. We do that, and it's an open agenda. They bring everything to that. And all the time that this was happening, the paediatrics and the A&E at Grantham, we ramped that up because we needed to make sure that people were informed, and still we could have done better. We could have done more, but it's important to keep colleagues and teams informed. Take advice and support from NHSI and other dons and their teams, which I've talked about. Leicester and Nottingham were particularly helpful for me, and NHSI, Anne's team, Lorna and Mark and others. They came up to see us, you know, we sat around a table, we all banged our heads on the table together and said, what can we do that's best for the patients here? And we came up with our plan. But the other thing for me, and for all your chief nurses, and I speak particularly for chief nurses now, is that we do actually have a corporate responsibility. So I am a corporate director of my organisation. I sit on a trust board with a corporate responsibility to bring finances in at the end of the year, to ensure performance is right, to ensure quality is right, and then I'm the nurse director as well. So for chief nurses, well, certainly for the ones that I know, and for me personally, it's really hard to do them both, because I just want to chuck chief nurse in every time, you know, and get my shroud out and say, you know, it's me, listen to me. But actually, you do have a corporate responsibility. So when you're providing that information that's going up to the trust board, you need to bear that in mind. So if you get into any of those places, as I say, I've a bit of a panic, and that's okay to do. Remember to scrutinise all of the information that goes up there, every single thing. Our board, and you'll see if you wanted to read our CQC reports, which I'm sure you wouldn't, but our data that's been going up to the trust board, it's not good enough all the time. So we report falls in several different ways. We report 1,000 bed days, we report ST, we do it through safety thermometer, through SQ SUD. We report it in 3 different ways, and actually you can choose which one you want, which gives you whatever outcome you're looking for. So you have to be dead clear about scrutinising the information that goes up. Risk assessment and QIA, I can't tell you how important it is, and we're not getting it right. One of the reasons that I wanted to come a bit earlier today was to talk to Lorna, to say to her we need some more support at ULHT because we haven't got this right yet. Importance of assurance, not reassurance. Can't emphasise that enough, as everybody else have. And it's important that you get oversight from the exec. So if you're worried, if there are issues in your area and you don't feel that people are listening to you, you've got to keep pushing it. You've got to keep pushing it. You have to have oversight by the execs and the non-execs that sit on the trust board. So, my final words would be, get support from your colleagues, always keep true to your values, put the patient at the heart of everything you do, and be really proud of how hard you work and how difficult this job is for us all to do at the moment. And I think if you keep those things in mind, when you look at the Safe Nursing Cares tool, you look at your establishment reviews, go back to the patient every time, be proud of everything you're achieving, because it is really hard at the minute. So that was all I wanted to say. Thank you.